to TNT Open Mind Insights. Amber, I'm so pleased to have you join us here today. I've had the pleasure of interviewing you 3 times and seeing you in action.
Absolutely.
And to be able to bring this story to this audience is very meaningful. So thank you for joining us today.
Thank you, Autumn, for having me and bringing me down here to be able to share with UC Irvine and the fellowship experience, strength, and hope, and how they can help their patients in the patient room and in the patient setting find hope and healing.
Absolutely. And we are filming at a conference that has 350 fellows
Amazing.
working to shift and change, stigma and healthcare for folks everywhere. And each one of these, it's like a ripple effect. One person affects the next, affects the next. So it's super exciting. And to have you here speaking is wonderful. So you are the CEO of Janus of Santa Cruz, and you help build programs throughout the continuum of care
Hmm.
for substance use disorder. And what I love about how you think is that you know no boundaries. Like you're really looking at who these folks are, what they're struggling with, and how you can come in to assist them at various levels and various places along their journey. But before we get into what you do, I want to take a step back to the beginning of where you started your journey in this career. So, how did you first meet Janus of Santa Cruz?
I was a patient, so I was in the hospital giving birth to my son, and a social worker came in and basically said, "You need to go to treatment." And so I was a young mother, a teen mom with a young baby, and basically a child
Mm,
raising a baby, and was recommended to go to a treatment facility at the time. Um,
so, had your baby already been born, or were you pregnant when you entered the
yeah,
place?
he had been born, um, and I went to a private facility first and realized, like a bougie treatment center. My dad had insurance and Blue Cross, and when they called to do the utilization review, um, they only covered 21 days of treatment. And DHC, Child and Family Services, said, no, you need to do longer treatment with the baby. Um, and so I was introduced to Janice at that point. I went from this bougie treatment center to this kind of like rundown facility. And so to me, walking into Janice Perinatal with my son um, opened my eyes to what needs to change. I mean, instantly, I remember the day I walked into Janice Perinatal and I was said, I'm going to change this and be the CEO one day. I'm going to change how we are treated. How just because um, you don't have insurance or your insurance stopped covering a private facility, and now you're in a public facility, the care is vastly different. And that makes no sense when it comes to human kindness and care and dignity and respect and generational impact, women and children. I mean, we have opportunity here to make an impact generationally on people. So
Hmm.
that was my experience. I walked in as a patient thinking I was going to own the place right off the bat. Over the years, I was humbled and brought back down to planet Earth with expectations and honesty and humility. Um, and so, yeah, I was a patient first at our perinatal facility, and I was there for about 10 months inpatient care, and that's unheard of today. It saved my life, and I was just inspired.
Hmm.
Um, it's been my life's mission. I feel like this is what I was born to do, is to put the client at the center of the decision-making process, not money, not politics, not other people's agendas or short-term ideas, but really how do we put the client's care at the center of all decisions being made in this space.
That's been your North Star.
Mm-hmm.
Yeah, and you keep going back to it.
Mm-hmm.
And life is going to be up and down. You're going to have moments where you're feeling on top of the world, and like you said, moments when you're humbled. But if you can keep that North Star at the center Because I think I've heard you say, if you've got a decision, you go back to that,
Yep, every
right?
time. Every
Yeah.
decision I make, I check myself. I have the chief team and the other staff check themselves. Um, and we all kind of check ourselves. Are we doing this in what's the best interest for the client walking in the door, the patient walking in the door?
Yeah. So what inspired you said you were inspired to be there, but at the same time, you experienced the difference between, a bougie facility and, a more
Yeah,
publicly funded
yeah.
place and seeing the difference. Was that the main point of inspiration or was there something else about uh, substance use
It,
treatment?
I think for me, what's really important, and if you were to come to any Janus facility, you would feel this today. That's been my as we kind of fast forward into what I'm doing today. But my main goal when I was appointed CEO 5 years ago: environment, environment, environment.
Mm,
Environment is everything. If we give our clients something to rise towards with accountability, they do better. I do better. I did better. I believe that it's all about environment. Um, my children, my son was born addicted and he's never had a problem, but I've given him an environment to thrive in: sports, team sports, education, a place where he can feel safe to talk about how he's feeling. But it's always been about environment and what I'm exposing him to, or my children to. So I just really feel strongly that our clients deserve beautiful environments, just like any bougie treatment center. It should all be the same. We should be payer blind. Anyone should be able to walk into treatment and get the care they deserve. And when a client today writes on the wall in facilities, oh my God, they wrote on the wall. Okay, bring the paint over to them, give them a paintbrush. That's called accountability.
I love
So,
that. Yes,
it's
we
like,
can fix this.
yeah, like you
Yeah.
teach people how to give back too. When you
Mhm.
can raise their expectations of themselves
Mhm.
by giving them environments to aspire towards, then
Mhm.
you can increase their accountability in taking care of those
Yeah.
environments. And then what happens as a result? They pay it forward.
Yeah.
It's, to me, simple, um, or it feels
But
simple.
you have to carry it out. That's
Hmm.
the hard part because people can understand a concept, but actually putting it into motion. Which, speaking of putting it into motion, you know, we have to really applaud you now for the new perinatal facility. So tell me, like, what you've built.
Yeah, it's been we at Janus have built this. I can't take all the credit,
No, of course.
but there's a beautiful 25-bed women and children's facility being built right now. We will ribbon cut it September 22nd, my birthday. I picked
Nice.
that day because that's where I got care, and we're celebrating 50 years, and it's a landmark. It's the first infrastructure project we've done. We have multiple going right now, but this is where it kind of started. And starting with perinatal was important because that's where we make generational impact. When we have children in our facilities, those children need environments too to
Mhm.
aspire towards and love and care. And if we can make an impact, it will have ripple effects for generations to come. The work in perinatal is so special because of that ability to make that impact. We have women come back years later with their children. We have children come back and give back that have been through these programs. My son still, wraps Christmas presents for all the kids at perinatal every year. Like it's pretty incredible to see the generational impact. So it only felt fitting to start there,
Mhm.
and our 50-year celebration to start with really investing, or the behavioral health continuum infrastructure project. The governor's made historic investments in infrastructure. We probably will never see again this type
Oh,
of
I hope
investment.
not. I mean, I hope
I
we
hope not
do.
too. I
Yeah.
hope we do too, but it it's a lot. He made a really big investment in infrastructure, and that's kind of never been done before, um, since the mental health hospitals closed in the Reagan administration. So our perinatal facility will open. It will serve 25 women with children up to the age of 12. We are partnering with the Office of Education to take those children to school. We'll have behavioral and like cognitive therapists on site. Um, Whatever it takes
Yeah.
to get these children opportunity and their mothers opportunity. Um, it's not a choice. A mom doesn't choose to pick up and use when she's pregnant. This is a medical condition and it needs to be seen as such and treated as such. And Yeah, so I think she's already struggling herself with shame and guilt to even walk in the door. So it makes sense we started with building out this facility, and we at Janus look forward to delivering a beautiful facility to our community and the 4 communities around it. It's a regional project,
I
so
love that. And it's kind of a rare facility too,
hmm
isn't it?
yeah, very few in the state.
Why is that? I mean, we're talking about mothers and children, and the alternative to a place like this and what we normally see is really sad.
hmm
I mean, what normally happens to a child born addicted and what happens to the family?
They, what happens to them right now is they sit in the emergency room department and they get seen in labor and delivery and they feel judged and shamed by all the providers coming in and out, and the providers are having their own biases come up in the setting, and so they don't get care.
Mhm,
They don't walk into care. They end up
mhm,
in delivering in hotel rooms, and
mhm,
it's really and there's a lot of research and data that supports that. It's interesting. Recently, they said, "Oh, the need of women and children seeking treatment and or coming into the emergency department and disclosing that they have a substance use disorder or that they've been using substances has gone down." And challenged that and said that's not the case whatsoever. What's happening is we're not assessing them properly.
mhm.
Providers in that setting where it's quick in and out, we're not assessing and asking the questions that need to be asked with the right people asking the questions.
Yeah, and
So,
in a safe environment
yep,
and like a pathway to get help because from my understanding, if you give birth to a child who's addicted, that means your child's going to be taken away from you,
right.
right?
And if the providers are so busy in and out of patient rooms, as we know, our emergency departments ever since COVID are inundated. There's a lack of providers, a lack of clinicians and providers to provide addiction medicine in California, everywhere, really. Psychiatric support or psychiatric medical providers or mid levels are almost to be unseen. We call them the unicorns because there's like 2 in our community. We had a job posting for a psychiatrist. We had to close it because there isn't any that want to work in the
Wow.
field.
Oh
Like
my gosh.
no one applied. So I think providers, one, knowing how to assess and ask the question, and two, moving their biases out of the way, and three, being able to connect the patient or client or mom to care, the appropriate care. Um,
Yeah.
yeah,
That leads me perfectly then into the healthcare environment and how we talk to people with substance use disorder, and that's what the whole point of this conference is to learn those skills. But can you share with me some of the barriers that you see healthcare providers facing and even wanting to engage in this topic?
absolutely. At Janus, we um, alongside our 2 CEOs ago, wrote Assembly Bill 848, which brought medical into the residential treatment setting. And that was in 2015. And at Janus, we got to work alongside Department of Healthcare Services and wrote the regulations to bring medical providers into the setting. I mean, previous to 2015, we didn't have medical providers anywhere.
Oh,
So this is new
huh.
in residential treatment settings. So it's a new concept. Um, and at Janus today, we have a full working medical service. Everything we do is, on the gate is kind of medical. They're seen by a provider, then they get whatever prescriptions or prescribing. But one is the availability of time. Yeah, providers are used to a value-based payment model system where they have 15 minutes with a patient in a room, and our clients and patients historically are very time consuming. So they don't have an hour or 2. So there's that, I think, right off the bat, is that I don't wanna take on a patient with substance use disorder because I don't have the time in my schedule to meet my key performance indicators, my KPIs, or my goals as a provider or
Hmm.
prescriber. So there's that. That's just right off the bat. I think secondly, um, there there's this risk aversion in the medical profession where they don't want to they see our clients as risky. I heard it today. I attended a
Mhm.
session already this morning, and a provider said I didn't want to prescribe buprenorphine because it just felt like I was giving another controlled substance on top of another controlled substance. And that is a misnomer. You can
Mhm.
prescribe as much buprenorphine. There is a ceiling effect. They're not going to be high. Um, there's no risk whatsoever.
Mm.
Good Samaritan laws, protect Narcan for overdose. You're saving a life by prescribing buprenorphine or Suboxone. Um, and so there's these ideas that are floating around out there that are just um, old school and not right. And that's that risk aversion piece.
Mhm.
I say to that, okay, if you have someone with congestive heart failure coming in and they're not med compliant, or a diabetic who's not med compliant and going into diabetic comas at Thanksgiving or during the holidays, and you're being called in as a provider to the emergency department or to the hospital med surg floor for your patient, that patient is just as risky as one of our patients
Mm.
that's suffering addiction or substance use disorder. So it's really in how we look at it. Um, Prescribing naltrexone, prescribing buprenorphine, there is absolutely zero risk in that. Um, and it has the potential to save lives. We've
Mhm.
seen it. There's
Mhm.
research, there's data that tells us that.
Yeah.
So I think that's two, one and two. Three is, I would say, um, so time, risk adversity, and aversion. And the third one would be their own biases showing up in the
Mhm.
work,
Mhm.
um, their own judgments showing up in the patient space of, I don't really looking at addiction as a moral failing
Mhm.
instead of a medical condition.
Yeah.
I would almost bet providers don't even know
That
that
they're
they are
doing that or
internally
feeling
have
that
these
way.
biases that are based on a moral failing
Yeah.
and not in their own training.
Oh, yeah.
So
That's
um, I would I would challenge any doctor or fellow to push beyond that and listen and take care of themselves and have conversations and support groups around what is coming up for you when you have a patient in your patient room that is coming with an abscess from injecting heroin or fentanyl, and what is happening for you in the moment where you don't feel confident or comfortable prescribing buprenorphine or connecting them to resources
yeah.
outside of that
So
setting.
that part is that self-awareness
Hmm.
piece, and you've also experienced this,
Yeah,
and your self-awareness helped you address the situation. Can you tell me about that?
yeah. So I had my son when I was a teen mom, and he was born addicted um, to methamphetamines when I had him. Um, and I had used for a short period of time. That's no excuse. And 12 years later, I had been trying for 5 years to have another child. I ended up doing 4 rounds of IUI, intrauterine insemination, and then had to do IVF in vitro to have my 12-year-old daughter, um, who's brilliant and amazing today. But I worked at Perinatal, our women and children's facility during that time. And I started to feel pretty upset, uncomfortable. It was coming out in my practices as a clinician with the moms and the babies. The mothers were coming into perinatal and then leaving, and their children were going into the foster system or being adopted. And all I could think when I was working in that setting was, all I want is a baby, and you're here and you don't want your baby. And so those biases were coming up for me, and I work in the field.
Yeah.
Um, Day in and day out. And so for me, what I did is I went to leadership and said, I need to move to a men's program or a withdrawal management program or another site
Yeah.
because I'm pregnant and it took me 5 years to get here and $35,000 and lots of pain of hormones, injecting hormones in myself every day to get to this point. And can you move me sites? And so I knew and I recognized it and was able to move sites. And so I didn't burn out as a clinician. I was able to find my hope again and my inspiration for the work. And I eventually went back to perinatal and was the
Yeah.
director of that program after that. But I knew I needed a break
Yeah.
because of my own biases that were coming up in the setting.
So what did you learn from that experience that you could share with healthcare providers that might be struggling with their own biases?
Just check yourself at the patient door before you go in. If there's something you can tell yourself, like, this is a medical condition, I'm going to treat it as such. I'm a provider. That is my duty. Or know when you can't
Yeah, sometimes
and
you can't,
pass it
and it
off to
doesn't have
another
to be
clinician.
permanent,
Don't
right?
force it. Don't push it.
Yeah.
I like to say that our patients and clients that suffer substance use disorder are some of the smartest in the world. I mean, they're brilliant when they get clean and sober and they change their lives. They're brilliant. They make, I mean, musicians, artists, so many people I can name in the world that are incredible human beings. Um, so I think looking at it from that lens as well, that
Yeah.
you have an opportunity to save another life
Yeah.
and um, check your bias at the door or hand off the patient to a colleague.
Yeah, hand them off, and then I'm sure there was more to your awareness as well too. I mean, uh, how does I think you have to have some self-compassion
Hmm.
around it, right? And where does that come from? Could it be therapy? Could it be, I mean, how do you take care of yourself in order to show up for these tough topics on a regular basis?
I mean, you have to. There's no choice. And I definitely want to discuss providers having challenges with substances too. But um, therapy, like for instance, at Janus, what do we do for all of our staff? We have free therapy on demand.
Oh, wow.
When I was appointed CEO, I remember I needed therapy one time and I went to HR. This is years before that. And I was handed a pamphlet. And I'm not going to say the insurance company, but it didn't matter because I was handed a pamphlet and it said, call this number for therapy. You get 2 free sessions.
Okay.
So I call this phone number and no one called me back for 2 weeks. Could you imagine if I was
Yeah.
in like a crisis?
Yeah.
I mean, no, 2 weeks, the crisis is over. It's been done, dealt with, or I'm gone, or whatever.
Yeah.
So I think for me, number one priority on the patient side, it was environment and access to care. On the employee side and wellness, it was free therapy for all the staff right away,
Yeah.
on demand, whenever they need it, and for real, on demand. Not just, we're going to hand you a pamphlet, we'll see how it goes. So we hired Elizabeth Morrison, that has that
Oh, yeah,
organization
I know
called
her.
Flourish. And Flourish is, they do 15-minute sessions, they do hour-long sessions. You text them, they get back to you within an hour,
Nice.
24/7.
Wow.
So all of our staff have access to free therapy. I utilize therapy too, so I practice what I preach.
Yeah.
Um, and I expect the staff to do the same.
Mhm.
So, or we expect the staff to do the same, to have good self care. We have self care days
Oh,
in our time off. So they're just days to take care of yourself.
nice.
I think we have 2 of those. We have 2 mental health days. So, like, we do as much as we can to support each other in this work because it's so challenging.
Yeah.
So challenging that, like, in the parking lot, we're doing Narcan overdose reversals. Um, I
Oh.
mean, that happens in real time at all these treatment centers in California. It's just not highly visible, but our staff are saving lives in our parking lots. Um, and so they need their lives saved too.
Mhm. Yeah. Yeah. And then can you talk too about like uh warm handoffs and this idea of like getting people to care rather than like handing a pamphlet and sending them on the way, because there is, the providers that face these 15-minute windows.
Yeah.
How do they ensure people get connected to care when care is not readily accessible?
They get them connected to care. Like for me in the setting, I think about providers. We have medical providers in our setting too, and they're in the room for I mean, they're in the room a little longer than 15 minutes, but they're in the room. And so we have medical assistants. For instance, if I go to see my primary care provider, there's a medical assistant that's doing most of the work. Some FQHCs have substance use navigators or an OBAT, office based addiction treatment component. And you can pull in those social workers to meet with that client after you've done your 15-minute, where you're preparing prescriptions and talking about what challenges they're having. I don't ever encourage providers to get into some full, counseling session. That's not their scope. They're there to do the medical side. But pull in the medical assistant or the substance use navigator or your colleague, your social worker, to come alongside the patient while you're seeing other patients. They can sit in the patient room still. You don't have to room another patient and have them sit in the lobby. Or you have a case management office, or a medical assistant can sit there and make phone calls with them and do
Mhm.
a warm handoff.
Mhm.
The medical assistant or someone administratively can come up with a one-page resource list of
Yeah.
who to call in the area. So I think challenging ourselves to know the services, understand them. I would also challenge providers to go to the treatment, spend a day or an hour out of your day to go look at one of the treatment centers near your practice
Interesting. Yeah.
and just look at it, meet the people face to face. I mean, that I learn best that way is face to face. And so I think to understand the care and the services, especially in this program, you would think 350 fellows are here learning about addiction medicine. You're inspired enough to travel here
Yes.
to come
Yeah.
to this. I would hope you'd be inspired enough to go to your nearest treatment center.
That's such a great idea. And I think people don't necessarily think to do that, but I'm a big fan of that too. Just that in person means so much more. And when you see things face to face, and do you think a lot of places would be receptive to a healthcare professional coming to observe?
Sure would hope so.
Yeah.
We need more doctors in our field than ever before. I would think we would open the doors,
Yeah.
with
Just say, I
open
want to come
hearts.
and learn and observe and meet some folks and help improve my practice that way.
Hmm.
Yeah. I love that idea. And then you also mentioned there's a warm line in California.
Yeah,
Yeah.
there's the 988 crisis line. There is there is the ED Bridge, which is a buprenorphine bridge program for providers where they can do 72-hour prescribing, and the bridge program will help connect. They also have prescribing practice guidelines on their website that are perfect if you're feeling apprehensive to prescribe buprenorphine. Pull the practice guidelines. They have the prescribing um, algorithm sheet for how to prescribe and in what dosages. Um, and I will be sure to add that to the resources in the app.
Yeah, so we'll have links at the bottom of the page to for all those resources, but just taking some time to get to know the topic and creating a resource list. I
Yeah.
mean, that takes a couple hours to just do the research, and then you have that ability to address those folks that are coming to you. And then what would you say about just the landscape overall of substance use treatment in California, maybe even beyond California? Like, how well are we facing the challenges that exist?
Whew, um, I do some work for AB 848 to stand up medical across California through the Center of Excellence at the center at the Sierra Health Foundation through DHCS, Department of Healthcare Services. And for instance, next week I'm going to go see 30 organizations in Southern California and set up peer networks. Uh, I think ever since we launched fee for service, there is going to be a challenge. We're going to see small mom and pop shops that don't look at treatment or nonprofit as a business, and they haven't looked for efficiencies. In our old school settings, or that we're kind of behind the times in the sense that we were cost reimbursement. The counties would true us up at the end of every fiscal year, so there's no need to get efficient.
Hmm.
There was no need to
Oh,
have less
interesting.
administrative staff, have key performance indicators and outcomes on the client level, units of service, what they're delivering, care delivery models. None of that. There was no incentive. It was social justice warriors spearheading their mission and drive that was deep in their gut and their heart. And today there's a call, because we're in fee for service. We're 2 years into fee for service, which is dependent on the service. That's how you get paid a fee. Um, and we have so many providers that are dropping into the red because they don't know how to get efficient. Administration's no longer paid for. Your
Mm.
administration teams don't get cleared up. So we are trying to travel and set up peer networks and help as much as we can scaffold so that we don't have closures and program
Oh
closures
gosh.
across California, these smaller organizations that don't have efficient systems or don't know how to do a Lean Six Sigma or a PDSA cycle, or change management framework really well. Um, so I do think that we're going to see less availability before we see more
Uh-oh.
as we're all building this infrastructure.
Mm.
These beachhead projects are going to build infrastructure, but I think as fee for service continues to settle in and counties um, don't have funds left in their general fund right now, we see the budget crisis happening right now. It's happening in every county across the state. So they're going to start to peel off those general fund dollars that they've been floating these programs with for the last 2 years, and we're going to see it hit in the next year. So I think as much as we can provide business acumen, training, and support to the CEOs and leaders of these organizations, the more availability we'll see on the patient side. We will probably see crop ups of hospital hubs and regionalized centers,
Mhm.
like Janus is doing, and Tarzana and Health Right 360. We all are building these regional, Fred Brown are building these regional centers. They're going to get bigger, um, like the Reagan hospital days. I think we're kind of turning back
Yeah.
towards that. Um, and then go ahead.
Yeah, so there's a lot of work to do,
Mm-hmm.
obviously. Oh my
Yeah.
goodness. But where out of all of this, like, where do you find hope?
Oh my gosh. I don't know. I have an empty well of hope.
An empty well?
I mean a full well. It's
Okay.
I mean there's no it's bottomless, bottomless.
Oh, a
It's a
bottomless
bottomless
well
well
of
where I
wow.
have continual hope all the time. I'm inspired every day by people's stories, inspiration. My father passed in 2009 um, to alcoholism, and he needed these services. He needed a medical provider to come alongside him and give him naltrexone or something, and that didn't happen. And he was incredibly brilliant man. Um, and he was one of those people that thought, not me. I have a master's degree. I'm a scientist. Um, I don't belong there. And he wasn't able to get the care because of both between the medical side of it and the environment.
Mm,
So I think my inspiration is not going to go away. I felt like I was born for this mission. Um, and I will do everything in my power for probably for foreseeable future till I'm gone off this planet, to help decrease stigma, save lives, help people find their hope and joy that's there, and help them find it and pick it up themselves. We don't save lives; we help others save their own.
I love that.
Yeah, so just it's endless. Um, I I'm every day. It gets tiring sometimes, but that's where you add therapy and you take vacation. And every year I go out of the country for 2 weeks. Um, so my children are my inspiration. I mean, that is a direct result of environment. None of my children have a substance use disorder whatsoever. They know everything about it. If they go to parties, a baseball college party or a friends, they bring Narcan with them and hand it out like it's nothing.
That's generational impact.
And that's generational
Yeah,
impact.
I love that.
So that's what is in front of us for all of us to, or fellows or providers, to find their inspiration and joy.
I love that. So you're servicing the full continuum of care for substance use disorder, and this is actually, I mean, there's so many different substances, so many different populations out there. We talked about the perinatal need, and you have so many different, places where you're helping the sobering center and whatnot.
Mm-hmm.
We could go days and days on all
Yes,
this,
we
but
could.
what are some of the special populations that you find are left out of the conversation?
Um, I know that, I mean, for me, I'm committed to the aging population and the 65 and older Medicare patient that is left on the med surg unit. 15 years ago, I was downstairs at the hospital at a high utilizer meeting, and we called them hug meetings back then. I don't know what they call them now, but it's high utilizers that utilize the system of care that are struggling with substances. And I remember Dr. Greg Whitley, who's now the chief medical officer at Dominican Hospital, um, turn to me and say, So when was there going to be a program for the 65 and older aging population? Because they're all sitting on the med surg floor with other comorbid medical conditions, and they're staying longer because their alcohol use disorder, AUD.
Mm,
And it just like hit me. And so I became really passionate about that. Um, and my dad, my father, would probably be here today had he gotten the care he needed on the medical side, and it was treated as a medical condition instead of a moral failing. So, at Janus, we're in the process of getting a 3.7 chemical dependency recovery hospital designation.
wow.
We already have a Medicare contract, and the combination of those is will be one of very few in California that will be able to treat the aging population, 65 and older. And that's a higher level of care, that 3.7. That's medical, a lot of medical support. Um, IVs, wound care. So it's a very needed population to serve. I don't know if anyone has Medicare contracts in the state, but uh, I would want my father to get the care through Medicare, and I hope that the rest of everybody in this room and who's watching this would want that for their parents and loved ones. Instead of sitting in a hospital being treated by hospitalists that don't have experience with substance use disorder.
Yeah.
So um, uh, we are definitely working towards having a fully materialized hospital that just treats chemical dependency uh, patients. How beautiful would that be? I'm an ambulance. I can go left to a regular hospital for congestive heart failure or diabetes or a coma or accident, or I can go right to a substance use disorder chemical dependency recovery hospital.
Oh, wow.
Um,
That's quite the vision.
I mean, it's a big one, but
Yeah.
I think we can get it done if we all
And the
work
need is
together.
there.
The need is absolutely there. They're already all sitting in hospitals.
Yeah.
It's they 1 in 3 patients in a hospital stay have a substance use disorder. 1 in 3. 1 in 5 visiting the emergency room have a substance use disorder.
Yeah. Wow.
They're staggering numbers. If you can go left instead of right and drop those numbers drastically, it justifies itself.
Yeah, absolutely. There's a lot of people doing great work like yourself, and
Mhm.
thank you so much for coming and speaking with us on
Thank
this
you.
topic. I really appreciate it. And this is just a slice of what you do. There's so much more to learn. So there'll be more. You can learn more about Amber in the links below.
Thank you, Autumn, and Open Minds and UC Irvine TNT for having me.